Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now. All right, welcome to presentation or podcast number 3 of Cancer Myths, Cancer Truths, an evidence-based journey through the separation of fact and fiction as it relates to many things, oncology, integrative oncology, even natural oncology, because what this goal of this 7 plus 8 part series, which by the way, I'm giving a very brief overview at the Annie Appleseed here in just under a week down in West Palm Beach. If you don't know that organization, I please encourage you to catch that out. I want to empower you, the individual with cancer, the individual may be affected by cancer directly or indirectly, because it's only through empowerment that better prevention, early detection, better treatment, and healing strategies are available for you. We want you to be the best director of your care. So let's get into this, because this is the third part. The first part was war. The second was the systemic fallacy. This is presence equals function, if only. So what we want to look at here, presence versus function, is, let me put it in context, because what we have now is, I think about back in about 2010, 2012, on up to about 2014, there was a marketing campaign on low testosterone. You would see it in many parts of the country. Big billboards said, "Know your number." And they were referring to testosterone and merely basically whittling men down to their entire biochemical physiologic function on a number of testosterone, which by the way does fluctuate. And we actually see that right now where people are saying, "Know your number," but they're referring to lymphocytes. Now, lymphocytes, when low, lymphopenia, is a poor prognosticating marker for overall survival, but it's just not that straight cut. So what I want to do in this, presence does not equal function, is go into a very deep dive from that superficial presentation on the complexity within the immune system. And honestly, it supports why the war strategy is no longer the best strategy, and the systemic fallacy, the systemic approach, is no longer the best strategy. So I have to introduce you a topic here called spatial omics. I talked a lot about omics. This is the study of genomics, of genes, epigenomics, of epigenetics, transcriptomics, translation omics, and so on and so forth. Immunomodulomics, microbiomics, etc. But here, spatial omics is the study of spatial relationship and timing. And this can be defined within the tumor microenvironment. And that's in fact what spatial omics is. It's the molecular profiling advancement in technological measurement that allows us to look at genes, RNA, proteins, metabolites, or even states of chromatin assembly within the preservation of the spatial localization within intact tissue. So it's basically giving us a live model, not just of the presence of immune cells, but the relationships of them. And the key requirements here are molecular measurement, spatial coordination, so where they are in relationship to each other, and then where they are in relationship to tissue architecture here, and the tissue architecture being preserved in this evaluation. The crucial distinction here is that if this spatial localization is lost, then in the measurement, it's not spatial omics. And the context here of these immune cells and this immune relationship and this immune timing, it's critical. Omics plus histology plus spatial coordination. That's what spatial omics is. That's a deep dive. Now, the spatial omics really unveils, and it's helping to unveil the tumor microenvironment. We'll do a quick review of that here in just a second, but it allows us to look at the intricate organization, the structure, and the interactions of cells and immune cells within the tumor microenvironment. It shows us immune cell distribution and how they're interacting with each other within the different spaces of the tumor microenvironment. And it helps us to move beyond just simply the expression, right? Estrogen receptor positive breast cancer, as if breast cancer is only governed by the presence of estrogen receptors. Now, that gives us a key mechanism to attack, but breast cancer is so much more complicated than that. And so here we can actually move far, far, far beyond the mere expression by cells of proteins. Critical interactions, and you're going to see at the end of this podcast, the interactions are the interactions spatially are much more important than the mere numbers of cells, and this is critical in immunotherapy response and the resistance to immunotherapy. And I would say resistance to other therapies as well. And it's going to give us insights that are precise and targeted. So it's not just seeing the immune activation, it's showing us the potential for new biomarkers to follow. It's giving us better insights to the tumor and the evasion anti-tumor mechanistic activities. And so that's going to enable us to create better strategies to target the tumor in its precise manners by which it is actually invading. So it's actually going to help us to be better targeted physicians, which is going to make your outcomes as a patient or family member affected better. And it's a rapidly evolving field. And I do believe that AI, spatial omics, the concept of computational evaluation is really going to help us to advance this, and super excited about what this will bring in the future. And again, remember, it's always natural, holistic, and integrative, and yes, maybe sometimes even conventional, to bring this to the forefront to give us the best results. You walk outside and break a hip, I'm not going to tell you to take more vitamin D, but we can definitely help you prevent and then heal better from that. But when you combine these together, when you stack natural, holistic, integrative, and yes, sometimes conventional therapies, then you get better results. But of course, what we're doing is we're taking it right to the tumor where all of this spatial and timing is important. So why spatial omics is critical, why it's crucial in oncology, is it's basically unwrapping, if you will, the critical factors that are working together that influence how cancer initiates and how cancer survives, thrives, and progresses into that disease that we so fear. But turning that away from the fear to hope, we can actually use that to develop targeted strategies. So it enables us here, spatial omics, precise measurement of immune exclusion zones. See, just simply stimulating the immune system, your number in the periphery of the blood, doesn't mean it's getting in. The tumor stromal barriers, the tertiary lymphoid structure formation, the antigen presentation niches, the hypoxic gradients, and the macrophage suppression clusters. See, without this spatial data, many tumors appear immune positive. And it would just make cancer treatment so easy, would it not? Know your lymphocyte numbers in the periphery, and that's just going to, be positive immunologically in targeting, eliminating the tumor. And we know that's just simply not the case. But what spatial omics and that data shows us is that immune cells are, what you can see is that the immune cells can be mislocalized, they can be ineffective, and they can be just simply outright not there, absent. And so what the spatial omics allows us to do is to know where the immune cells are and what they're doing in relationship to each other. So it's a very exciting advancement into the tumor microenvironment that's going to, I think, bring us great therapeutic strategies. That's why I'm so excited and so bullish on the future of cancer care naturally, holistically, and integratively. So let's look at some key spatial biological insights about the tumor microenvironment that we're discovering from this process of spatial omics. What we know is tumors are very structurally organized. They're not this loose collection of cells. They're very organized in cell type and spatially in relationship to each other in very distinct ecological niches. They are structured ecosystems rather than homogeneous masses of cells that may include immune cells. Now, we like to think that tumors are uniform, but they really are complex dynamic environments that are composed of many different types of cells that are spatially distinct in their ecological niche or collection, if you will. So let's go through what is currently understood. And of course, with science, because science has never settled, we will evolve in our understanding, but we will always use spatial omics to do that. So first, there are tumor proliferative cores. So these are meeting that very well recognized pattern of behavior of cancer where it grows, it rapidly divides. Replicative immortality, as it's called, is one of the hallmarks of cancer. High metabolic demand and specific genetic alterations. And so when you're looking for those genomic sequences that are characteristics from tumor that's driving rapid growth, that's what you're looking at here. But this is a very specific core, a very specific zone or niche. Then there's stromal invasion fronts. This is where there's extracellular matrix remodeling and immunosuppression that's allowing the tumor cells to evade the immune system. We have immune interaction zones. This is where the fight's going on. This is a front line, if you will, where the immune system is fighting in an anti-tumor mechanism against the cancer because it's recognizing it, it's engaging, or the immune system is actually being co-opted by the tumor to actually evade the immune system itself. So that's the immune interaction zone. Vascular niche here, this is obviously dealing with blood vessels. Cancer needs rapidly growing blood vessels, and they are often abnormal. This process is called angiogenesis. It's driven by hypoxia, driving vascular endothelial growth factor, and this provides nutrient supply to meet that high metabolic demand of that replicative immortality. And you also need to remove waste, because with that growth comes waste. And that is a part of this vascular niche. And then there's necrotic or hypoxic regions. And this is where you get inflammation, immunosuppression, and treatment resistance. So you can see most people will focus on the proliferative cores and the necrotic hypoxic regions, but there's other regions here. And of course, all of these affect varying sensitivities of these tumors to treatments. So I think it's important to understand that the spatial positioning of cells determines the immune function. The mere presence of the immune cells means nothing to the function. It is their spatial positioning, it's their relationship. You can have a man and a woman that are just, a man and a woman, right? The presence. But it's the relationship that builds a 65-year marriage. And so that puts it a little bit in context, but here we're talking about the immune cell identity, and the presence alone of immune cells is insufficient to predict its function and efficacy in an anti-tumor way, particularly within the tumor microenvironment. So an effective scenario here in the spatial positioning of the immune cells to determine optimal anti-tumor function is that a CD8 cytotoxic T cell is near the tumor cells, and that is engaged it in anti-tumor cytotoxic activity. Okay, that is the effective scenario that we want, where the T cells have been primed and then they're actively engaging against the tumor to generate an anti-tumor immune response. And again, if, if that was only so easy. Now, the ineffective counter to that scenario is the same CD8 cytotoxic T cells are not primed, they can't see, and they're trapped at the periphery of the tumor, and they can't get in to engage against the tumor and effectively create an immune response. Thus, they are rendered ineffective. So here, function equaling the function of the immune system here in an anti-tumor way equals phenotype, what immune cells there, and the spatial location of those immune cells. So it's location and its context that is so important about the immune system, and why we can simply not say know your number. And again, it also supports the previous podcast, which I encourage you to check out, the systemic fallacy, why the systemic approach, I believe, is going the way of the dinosaur, extinction. So let's look at immune exclusion, because what you're going to see, and we'll talk about this in a second, there's immune environments. The assumption that just simply stimulating the immune system in the periphery, in the blood, simply engages the tumor is null and void scientifically. But here, immune exclusion is a concept whereby the immune system is kept at the periphery of the tumor and it's not able to engage. So where spatial omics really helps us here in these immune excluded tumors, by the way, which dominate the immune environments within solid tumors, is they help us to see these dense stromal barriers. Tumors don't just open the door and say, immune system, come get me. They create all kinds of barriers that disable the immune system to see it.
There's peripheral immune clustering. Again, what's going to happen here is the tumor is going to keep the immune system out. And so these barriers cluster them. And then there's reduced tumor cell contact probability. So if the immune cells, even if they're primed, they can't get into the tumor to engage with the dead cells or the parenchyma of the tumor cells, then there's going to be no engagement with the tumor cells. There's going to be no immune engagement. And so they give us these critical, quantifiable, measurable metrics, cell-to-cell distant distribution. Imagine this. Within the tumor microenvironment, we're able to see the cell-to-cell spatial relationship and how that affects function, and the context frequency score. So how well the immune system contacts and engages the cancer cells and what that then relates to immune function. And then spatial entropy measurements, which is basically the lack of order predictability. See, again, the more structured and organized the relationship of the tumor immune microenvironment, the better the immune response. If it's disorganized, it's going to create a dysfunctional immune response. And so the three immune environments that we can talk about are immune excluded, immune desert, and inflamed. Most are immune excluded and immune desert. Very, very few are inflamed. And even when inflamed, that's an active anti-tumor immune response. It's often inhibited, restrained, and dysfunctional. So tumor stromal interactions forms physical suppression zones. See, the tumor, it's like a old Star Trek. It's like a Klingon vessel, if you will. And so if you don't know Star Trek, these were the enemies of Captain Kirk. And they had these ships that could actually cloak themselves, invisible. They could just cloak and go invisible, and Captain Kirk and the Enterprise couldn't see it. So here, the tumors kind of do the same thing, but it's occurring in this tumor stromal interaction. And so what they do is they create fibroblast-rich blockade. So these fibroblast cells are blocking the immune system's ability to enter the core. And that's where they got to get into the core of the tumor. They got to get into the parenchyma, because that's where they're going to engage in the tumor-specific, tumor-associated antigens and neoantigens and really create an immune response. Remember, the strategy of the last 75 to 100 years has been war. There's been no thought, no engagement really on any level of the immune system. But the immune system is the body's defense. Its job is to protect the body against all enemies, foreign and domestic. Of course, cancer falls into the domestic category. Second tumor stromal interaction for suppression zones are myeloid suppressing firewalls, if you will. We think about firewalls of keeping viruses out, right? So that's from our computers and our digital devices. But here, what happens is tumors will recruit immune cells, myeloid-derived suppressing cells, T-regulating cells, and these will in turn create immune suppression barriers. So we have fibroblast barriers. We have now immune barriers. There's even acid-base barriers. And now then we have an extracellular matrix density and T-cell priming barrier. Here, the extracellular matrix is the scaffolding, if you will, outside the high replicating portion of the tumor. And this can become very fibrous and very structured and very rigid, and that disables the immune system not only to travel through, but to travel into. And effectively, this traps T cells, again, even that have been primed, meaning been primed and ready to engage with an antigen, that here being a cancer cell, it's stuck outside. And this is why when you engage with ablation intratumorally, you must preserve some of this function. Yes, you must break it down, but you must preserve it to enable immune infiltration. And thus ablation becomes not just a ablative or surgical alternative, but when you maintain some of that structure, you're able to infiltrate, you're able to bring the immune system to the fight and thus engage the most powerful aspect of your body and what it has to offer against the tumor. So these spatially measurable predictors, again, looking via spatial omics in the tumor microenvironment, they enable us to assess checkpoint resistance. And if we can assess it, then we can target that, right? poor immunotherapy response. When you look across the board at immune checkpoint inhibiting therapies, which are, when you look at immunotherapy as a term, we're talking primarily here about immune checkpoint inhibiting therapies, but understand anything that's actively engaging the immune system, mistletoe, fasting, yes, even repurposed medications like ivermectin, these are immunotherapies. But here, by looking at poor immunotherapy response, we can engage the immune system to generate a better immunotherapy response. Across all solid tumors, it's about 15 to 20%, depending on the study, that have shown immune checkpoint inhibiting therapies actually have an anti-tumor immune response. That's leaving, 85 to 80% of no response at all. And here I get so tickled when people talk about, repurposed medications. I love them, love them. Ivermectin. People say, oh, everybody take it the same. It's a protocol. So we go from a protocol of chemotherapy, we go from a protocol of radiation, we go from protocol, where we're blindly following recipes. And we forget that medicine is equal art and science. And so we forget that, or maybe don't even know, ivermectin has been shown in animal models to convert cold tumors to hot, meaning non-immunologic responsive tumors to immunologic responsive. So we should use repurposed medications to specifically target what is found on spatial omics, not treat everybody the same. We just cannot fall trap in the integrative, natural, holistic movement to the same things that conventional medicine does. Let's learn from others' mistakes and not make those same mistakes. But I'm afraid that we are making those same mistakes. So let's introduce also a topic here, and I've talked about it elsewhere, tertiary lymphoid structures. These are immune aggregates that are very important in their, guess what, spatial organization. So they equally are spatially identified as it relates to spatial omics. These tertiary lymphoid structures, let me define them here for you. They are dynamic, ectopic, so outside of lymphoid aggregates, so they're lymphoid-like, forming within non-lymphoid tissues. Let me rephrase that to better understand it. These are very immune complex collections, aggregations of what appears to be lymphoid cells, lymph nodes, but they're outside of lymph tissue. I think a better way to describe them or think about them is they are forward training immune camps. So it's like the enemy putting a camp that's forward to train right next to the enemy, because they can engage, they can take reconnaissance, they can understand the terrain. It's exactly what's happening here with tertiary lymphoid structures. And here, what's recognized via spatial omics is spatial signatures revealed, right? There's B cell aggregates, there's T cell aggregates, there's dendritic cell aggregates, and these are organized and ordered. They're not disorganized and they're not disorganized or disordered, okay? They are very structured. Yes, they may be heterogeneous, but they're very structured and regulated in their creation to enable them to be functional. When they're dysfunctional, they're disordered. The clinical significance here is immunotherapy response, or not just immunotherapy response, engagement of the immune system. Because if you're using low-dose metronomic chemo, right, that is an immunomodulatory response. You're engaging the immune system. But if here, if here we don't have structured tertiary lymphoid structures, you're not going to get great engagement. So, this is where I find it so fascinating. We have these regulatory bodies, state by state, state boards, and the federal state. I guarantee you they don't know this stuff. Okay, most of these docs, they're not practicing. So the people that make the rules and regulations aren't practicing. They're not staying up on the science. And so this is where the regulation, I think, becomes a bottleneck to innovation and advancement to help patients. So here it's going to affect the tertiary lymphoid structure and relationship via spatial omics. It's going to affect response rate of immunotherapy, or just simply response rate of the immune system be able to infiltrate and engage and activate against the tumor. And that affects patient survival. So it's not just the presence of specific cell types, or here, ectopic lymphoid aggregates outside of lymphoid tissue, but it's their intricate spatial organization and relationship that is important in treatment success and overall survival, which is what this is all about. So what about tumor behavior as it relates to molecular identity? Because we think about tumors and, okay, breast cancer, prostate cancer, pancreatic cancer. But we need to, again, I think, reimagine how we view cancer to better keep up with where the science actually is. And that's the precise spatial arrangement of cells, specific identical cell populations within tumors of not just tumor cells, cancer cells, but here also immune cells. And these share genetic mutations. And they have similar immune cell types, whether that be CD8 T cells, CD4 dendritic Tregs, myeloid-derived suppressing cells. So these tumor behaviors can be characterized by their molecular identity. And this is why there's even been suggestions in a few published papers that how we define tumors, we define them by the tumor microbiome. Now here we're talking about cells and the relationship spatially, but we've got to keep up with the science. And so any slight alteration in the spatial organization of the cells, of the mutations, of the immune cell types is important. But if there's any alteration spatially, relationally, it's going to affect communication, and it's going to shift the disease potential and the disease trajectory. So we can have the same cell population, cancer cells, immune cells. We can have the same shared genetic mutation, same immune cell types that are there, and yet their spatial organization does everything in changing the trajectory, whether that is regression or progression. That's how impactful this can be on clinical outcomes and treatment response or treatment resistance. So when we look at tumor immune failure, let's take a quick geometric look at this, if you will. So spatial relationships. I'm not talking about geometry, but let's look at spatial relationships geometrically. So the inability of the immune system to eradicate tumors, it's not because of lack of presence of immune cells. If there's one thing you take home from that, it's take that. But it's the improper spatial relationships and the inaccessible positioning of the immune system. So it's like you're setting up an attack on the enemy and your whole strategy is wrong. The communications are down. Your attack from the right flank is misaligned from the left flank. And just the whole defenses aren't organized and structured. That same concept applies here. I know I'm using that war metaphor because it helps us to easily follow these complex thoughts and processes, but there must be proper spatial arrangement and accessible positioning of the immune cells. And that's why tertiary lymphoid structures are so important to actually have effective anti-tumor immunity. So this means misplaced potential if immune cells are simply misplaced. They're not in the right place in the right time. Immune programs presented, but they must be spatially properly segregated. And antigen presentation is active, but it's distant from the T cells. So what this means is, we can have all the immune cells there. We can have the antigen presenting cells, the dendritic cells. We can have CD4 cells. We can have CD8 cells. And we'll talk about these in a second and what are called triads per the research. But if they're not spatially organized in the right area of the tumor or in the right relationship to each other, does not matter. It is misplaced potential. The potential's all there. You see it in an athlete, right? A tight end, he's 6'6", 250, he's got the speed, and he doesn't have the hands or the work ethic. And so the potential's all there, but there's something missing that just doesn't allow that potential to become reality. And so that's the same here. And so what this can help us implication-wise is really tailor therapeutic strategies where we can target specifically localized tumor areas to disrupt. No, we don't have to guess. The spatial omics gives us spatial definition of targeting. We can apply ablation to spatially remodel the tumor microenvironment to enable immune infiltration. And we can target intratumoral with immunotherapy to specifically target specific areas of the tumor. So again, what I say is when we put a needle in the tumor to engage with ablation, engage with immunotherapy, one needle stick now, two parts to this treatment, like 1A, 1B, but it's critical in immune engagement and immune activation. The needle doesn't go in just any aspect. It's going in one of the most hypoxic areas of the tumor defined by imaging. Now, spatial omics hasn't yet made it to clinical assessment, but when you look at a PET CT scan, what studies tell us is that in the most metabolically active areas, those correlate moderately, not 100%, but they correlate moderately with the most hypoxic areas, which are the areas that are driving much of the process of tumor growth and immune evasion. So if we want to target the tumor at its leading edge, we target it there. So this allows us to basically not just blindly target the immune system, blindly target the tumor by throwing something on the wall and hoping it sticks, but do so in a very precise manner. So I mentioned very briefly the intratumoral immune triad. So very nice study. Check out the show notes because it'll be there. I encourage you to check that out. What this study was looking at is, it was a study looking at spatial omics. But they were looking at the spatially organized immune triads, dendritic cells, CD4 cells, and CD8 cells. Now, dendritic cells are antigen-presenting cells that are core to immune activation. CD4 cells are helper T cells, if you will, that support cytotoxic CD8 T cells, and then dendritic cell, basically maturation, licensing, getting ready to engage. And then there's CD8 cytotoxic T cells. These are the T cells that are going on the anti-tumor attack. So when we look at this triad of responders versus non-responders, the responding tumors in this study, what they found is that it was the tight spatial clustering, was the intimate relationship, if you will, of the dendritic cells, the CD4 and the CD8 T cells. So CD4 cells, CD8 cells, and dendritic cells that generated the anti-tumor response. Spatial, not just number, spatial. It's like you having all the best recruiting numbers of the Marines, the Army, the Air Force, and yet they're all sitting around, not talking to each other, not engaging. They're in different parts of the world. They're all having a coffee break. But yet, if we had one Marine, one Army, one Air Force guy intimately communicating together in relationship, in sync, boom, you get a great, quote unquote, here, attack. Here, anti-tumor. Again, sorry for the war metaphors, but I think it hits home. Because I think war and cancer is something we need to move past. Also seeing in the response, the non-responders, what they found is that the immune cells, CD8 cells, CD4 cells, dendritic cells, they were dispersed. They were not spatially organized. They weren't communicating. So looking at the responders, there was active antigen presentation, meaning the dendritic cells were engaging with the tumor spatially and then engaging with presentation to immune activating cells. In the non-responders, there was a lack of T cell activation because there was a lack of antigen presentation. So it could be that the dendritic cells were not in relationship with the tumor to appropriately break down and present, or it could be that they weren't in relationship to the T cells. So they were in relationship with the tumor, here are the dendritic cells, but they couldn't then be close enough to the T cell to then present to the T cell to engage the immune system. Spatial omics is so critical. Now looking back at the response rate, tumor regression correlates with the triad formation. So in this study, the triad formation, the spatial omics, the relationship dictated the tumor response, here regression. But in the non-responders, the lack of spatial relationship led to a lack of effective immune function, meaning there was an absence. So let me recap. In the responding tumors with the triads, there was tight spatial clustering of CD8 cells, CD4 cells, and dendritic cells. There was active presentation and stimulation of the T cells within the tumor microenvironment, and there was tumor regression that correlated with this triad formation. In the non-responders, the immune cells were spatially dispersed, disorganized. There was a lack of antigen presentation, lack of immune engagement, and there was absence of immune activation, and it was because of the lack of immune triad formation. So the evidence base here on the implications, impact on the immune triad is profound. It really points to immunotherapy efficacy. Now, from a conventional standpoint, it's do these immune checkpoint therapies even work. And so we think about what's expressed on the cells. I kind of alluded to that earlier. Is it PD-1, CTLA-4, TIGIT, LAG3, TIM3, et cetera. These are all different immune checkpoints, but maybe why they work far beyond the expression of these immune checkpoints is the spatial relationship of immune cells. This explains why immune inflamed, which is where the immune system infiltrates the tumor microenvironment, why an immune inflamed can still fail immunotherapy. Because the spatial relationship doesn't allow the manifestation of that immunotherapy to work. Yes, the immune cells are there, but they're disorganized. They're not spatially related to each other. And this highlights how peripheral immune activation does not, repeat, does not equate to intratumoral immune function. There's too much that we're understanding now to simply look at systemic and go, that's the right delivery method. No. Whatever's going on in the periphery, in most cases, does not correlate to what's going on in the tumor. And we'll touch more on this. The spatial immune architecture, it's critical as a biomarker and potentially superior to even the biomarkers you hear about. The PD-L1 expression, the tumor mutational burden, the circulating immune cell counts. Get it? We got to think differently. Not just to think differently because the science is dictating that we do. Now, this translates very important to the clinical arena. And it shifts our thinking about immunotherapy from just merely the presence to organized immune function. This is why simply giving natural killer cells, giving lymphocytes, giving dendritic cells, this is why it can work in some, but it doesn't work in many. Because it's the same with immune checkpoints. See, we can take a more natural approach, natural killer cells, lymphocytes, dendritic cells, which is great. But it's not about the presence of the cell that's important. It's about the spatial relationship. It's the same as the immune checkpoints. 15 to 20%, again, showing efficacy in an anti-tumor way in solid tumors. So this provides, I believe, a strong rationale for intratumoral approach to correct those environments, to correct those spatial relationships. And yes, correct those dendritic cell, immune cell interfaces. This encourages therapies to actually target tertiary lymphoid structures within the tumors. We'll talk more about these in just a second. And it shows that presence does not equal function. That's the second time I've said that. Presence does not equal function. Relationship does. And again, that whole marriage thing. Man, woman, okay. But man, woman, close together, intimate, 65 years, marriage, legacy, children, grandchildren, etc. So the big takeaway here is that tumor eradication by immunotherapy requires intratumoral immune triads, immune relationship, immune communication, spatial coordination. Without it, immunotherapy fails, whether it's natural, holistic, integrative, or conventional. But with it, anything's possible. And we see this in relationships, right? When there's effective communication, the relationship does well. Still has its bumps, but it still does well. When the immune system doesn't communicate, same thing, it breaks down. And cancer takes advantage of that. So again, we're kind of moving beyond the concept of the 7 niches of the tumor microenvironment. So we're now getting into the more functional realm, if you will, because the way that we've looked at the tumor microenvironment, it's very isolated, compartmentalized, reductionist, if you will. And our understanding is that it's very dynamic and complex. So the 7 niches of the tumor microenvironment are the hypoxic niches, which is area, acidic niche, immune suppressing niche, inflammatory niche, perivascular niche, invasive front, and then the fibroblastic, desmoplastic niche. But again, we're kind of moving beyond this kind of concept because it doesn't really allow our understanding of spatial omics to affect what these areas are doing. See, reductionist fallacy is when we take complex issues and we compartmentalize them, reduce them into parts so that we can understand them. But what happens, and this is why the whole concept of holism was born, was because the reductionism, the compartmentalization, they were never bringing it back to the benefit of the whole. The individual parts were never brought back to the purpose of the whole. And so here, the same thing, we just focus on these individual 7 parts of the tumor microenvironment and don't reconstitute them back to the whole. Then we leave them in their compartments and we don't really allow them to show their true fruition of benefit or reality. And so thus it becomes false, a fallacy. We must always reassimilate them to the whole. It's called resynthesis. It's a higher order function. This is a little bit better. Key zones identified across different tumors. There's the tumor core. This is where the densely packed cancer cells are, mostly hypoxic and acidic, but though that can fluctuate. Often these are immune desert and immune excluded areas, which is important because this is where immune engagement and activation can happen. This is often characterized by necrosis and extreme metabolic stress as these cells are metabolically active. Check out the show notes of this podcast. You can see the studies that support this. The second key zone identified across tumors are invasive tumor margins. This is a leading edge of the tumor, the interface between the tumor and the stroma, because just as the immune cell must have the stroma to engage and enter, so the stroma must be changed to allow cancer cells to leave the nest, if you will. And this is the site of epithelial mesenchymal transition that I've talked about, where cells will go from immobile to mobile, and thus they are released from the bed of the primary tumor. But I think it's important to understand they're not released alone. They're released with other cells and cell memories. Here it's an environment rich in metalloproteinases, fibroblasts, and migratory cancer cells, platelets, etc., that are allowing the release, the breakdown, the release, the intravasation that it's called, out into the periphery of the blood to then metastasize. This is and often is the most immunologically active region. Then there's the perivascular zone. These are adjacent to blood vessels, tends to be high in oxygen and nutrient availability. Here, there's a lot of cancer stem cells. Remember, I've talked about the polarization where cancer cells can pivot to stem activity and back to non-stem activity. So we can't think of it just as a simply hierarchy model where there's cancer cells without stem and cancers with stem. It's a polarization based on the environment. The cells can go back and forth. But here's also the route for intravasation, leaving into the bloodstream from the tumor to go spread. And this is also where you get a lot of immunosuppressive cells like myeloid-derived suppressing cells and T-regulating cells and even macrophage and neutrophil polarization, where you get a shift from a anti-tumor M1 or M1 or N1 to a pro-tumor M2 or N1, what's called macrophage polarization or neutrophil polarization. Then the fourth here is stromal zone. This is where it's an environment that's enriched with cancer-associated fibroblasts, it's extracellular matrix proteins and inflammatory cells. And this is where you get a lot of barrier to the immune system or barrier to therapeutic or drug penetration from systemic delivery. Because as I've talked about in the systemic fallacy, 0.5 to 2% of the systemic therapy reaches the tumor. And so when you go, oh, it reaches the tumor, but does it get in? Are all the doors closed? Are all the windows closed? Because if 1 to 2% even gets there, and then it can't get in, it's an ineffective therapy. Again, it's the systemic fallacy. Check out that previous podcast. That was number 2 in this series. So key zones are identified, again, across the tumors. There are tertiary lymphoid structures. So you can see we're basically just going into the depth and the complexity. The spatial omics is really enabling us to understand that we just can't look at the periphery and think the presence of immune cells equals function. So there's tertiary lymphoid structures, and we'll talk about that in just a second, within different parts. And the spatial organization of these tertiary lymphoid structures determine the immune effects. B cells, T cells, dendritic cell aggregates, even high endothelial venules. We'll talk about that in just a second. And their location, their spatial relationship is associated with better prognosis and treatment efficacy. Then there's immune privileged zones. So there's tertiary lymphoid zone structure. That's the forward training immune camps, but even their relationship dictates the response. Then there's immune privileged zones. This is where immune cell infiltration is suppressed actively by the tumor, often by the tumor recruiting the immune system and co-opting it and turning it on the immune system. It's often dense in extracellular matrix, poor vasculature. You have things like same thing, myeloid-derived suppressing cells. You have immune signals like interleukin-10, transforming growth factor beta, indolamine dioxygenase pathways activated, adenosine is active here, and this is the presence of cold tumors. People say cold. The immune system is not engaged, it's actively suppressed. And we'll talk just a little bit more about that. And then there's necrotic zones. These are the poorly vascularized tumor zones characterized by cell death, immune debris, danger-associated molecular patterns. So though there's opportunities here for tumor, anti-tumor activity, there's also progressive tumor opportunity, so for progression. Again, check out the notes for the supporting evidence here. So I've touched on the three kind of immune environments broadly. And so we've talked about the spatial relationships here, looking at the different types of the tumor microenvironment historically, then the different zones and what spatial omics is showing us. Then we just talked about the key identified zones within the tumor of tertiary lymphoid structures, immune privileged and necrotic zones. But now we have to go back to that concept of cold versus hot. See, there's three primary described immune environments. There's the immune inflamed, which I touched on, which that even can fail. This is where you have active immune infiltration within the tumor parenchyma, the deep dividing cells. And the immune system recognizes the cancer, but it's functionally restrained. As I said, it's restrained, it's inhibited, it's dysfunctional. So here the barrier is at the level of immune function. The immune system's there and it's spatially organized somewhat, enough to have some activity, but the barrier is it's not optimized, it's hindered, it's inhibited, it's disorganized, and that most likely is spatial organization. The T cells are present, but they're exhausted, inhibited, suppressed. So the problem here is immune suppression. It's not absence of immune. The take home here is the immune system is inside the tumor, but it's restrained. Now, then there's the immune excluded tumors. Now, the inflamed tumors, that's about 20-25% of tumors. Most are not inflamed. The baseline of tumors are not inflamed. That means not immune engaged. So then there's immune excluded tumors, which is the broadest category. The estimates there are somewhere between 50 and 75% of all solid tumors. So a immune excluded has robust immune priming, meaning the immune cells are set, T cells are set to engage to the presence of antigens. But they're physically and biochemically, acid-base, kept out of the tumor. They're at the periphery of the tumor. They're ready to act. They see, they're ready to act, but they're kept out. So the barrier location here is not at the mere presence or immune function, it's at the boundary of the tumor. The tumor creates a wall. And here, the T cells cannot penetrate to activate. The problem is immune access is blocked. The take home here is the immune system arrives, but it's kept outside. And then finally, there's the immune desert, which is about 20 to 25% as well. And here, it lacks meaningful immune infiltration. The immune system has not been primed. It's not been ready. The immune system doesn't even know the tumor's there. It's not been engaged to activate. It's not been prepped. It's not trained. It's not ready. And thus it can't activate because it doesn't even see. The barrier location here is actually upstream of the tumor. It's actually upstream of the cancer immune axis. The problem here is immune ignorance. And again, ignorance doesn't matter if it's omission or commission, but here it's just flat out immune ignorance. It doesn't know the tumor's there. It doesn't know the enemy's there. It doesn't know it needs to activate. It doesn't need to know it needs to prep. The take home, the immune system never notices the tumor. So given these diverse immune environments that spatial omics is helping us with, systemic intravenous delivery, you can see how it's oversimplified to be effective, but here is often insufficient and ineffective because you're delivering something systemically that never reaches the site of the tumor that it needs to engage the immune system. So within the tumor microenvironment, and to convert cold to hot tumors, we have to understand that inside the tumor microenvironment are enhancing immune cell infiltrates. So to go from cold to hot, we must have enhancing immune cell infiltration. We must modulate the cytokines, which are immune signaling profiles, from one of cold to hot, one of pro-tumor to anti-tumor. We must increase antigen presentation. That's how you engage the immune system, with the dendritic cells being proximity to the parenchyma, creating the antigens, and then presenting them to T cells. So they must be in relationship with them, must have upregulation, a major histocompatibility class type 1 expression. We must have also a reduction of immunosuppressive cells like T regulating cells. All of this is the key to turn a cold tumor hot. And this is why I say what we're doing by going intratumoral to ablate and create the immune system infiltration, recruitment, activation, is we're taking the tumor and we're converting it into the source of a vaccine. Insight to vaccination. Again, that word vaccination literally means that which pertains to a cow, which here we're talking nothing about relates to a cow, but that's the cowpox being used to inoculate the immune system to smallpox. Inoculation is the key word here, is we need to turn a cold tumor hot. We need to inoculate the immune system to the tumor, not outside the body, inside the body, for proper spatial relationship to engage the immune system. And that's what is required for the abscopal effect. And again, strictly cold tumors, which are immune excluded, it's about 15 to 25% of tumors. That's an immune desert. These are lymphocyte depleted and immunologically absent, quiet immune environments, cold. Now, the functionally not hot, which gets classified and lumped into the cold, but really it's functionally not hot, is the 50 to 75% that are immune excluded, or you might say inflamed, altered. The majority of tumors do not exhibit, as I said, the majority of tumors do not exhibit an inflamed phenotype, meaning immune infiltration, immune engagement. And the implication here, most solid tumors are outright cold. The question is, what level, what degree of cold? So if we're working to engage the tumor by the immune system, we have to understand the battle, the barriers, what the enemy has set forth for us. Because if we want to convert cold tumors hot, we must properly engage the immune system, not just for the presence of immune cells, but the spatial to elicit function. So within the tertiary lymphoid structures, there's even organization spatially within them. There's even niches there. And so the tertiary lymphoid structures are not just defined by their presence, but they're defined by the presence of the immune cells in relationship to each other within those tertiary lymphoid structures. So it gets a little bit crazy. So there's the spatial organization that determines function of the tertiary lymphoid structures within the tumor, and then the immune niches within the tertiary lymphoid structure itself. See, this is why you go, oh yeah, just give this systemically, it's going to work. This is why it doesn't so often work. There's B cell zones. These is where you have active germinal centers, where you'll find these immature tertiary lymphoid structures. You have T cell zones. This is where you get the CD8 effector and memory T cells. This is how you can get an abscopal effect. Antigen presenting cells. And this must, again, these mature dendritic cells, which is very important because they can be immature, they must be located in proximity to both the parenchyma, the source of the antigen, but also the B cell and T cell interface. So it's not that these zones need to be present. They do. They need to be spatially organized to each other. And then there's high endothelial venules, which are specialized vessels that are vital for the active recruitment of naive and activated immune cells. So think of this as, as the, again, the war metaphor, sorry, but as the enemy, as you're progressing against the enemy, what must you do? Maintain a supply chain, right? And so you got to preserve that supply chain, because if that supply chain is cut off, okay, the enemy now is going to be able to get the upper hand, and here the enemy is the tumor. So this is a supply chain. These high endothelial venules are supplying immune cells that are ready to engage reinforcements. Without it, there's no reinforcements. So I mentioned these zones within tertiary lymphoid structures, but also the tertiary lymphoid structures within the zones of the tumor microenvironment. Tertiary lymphoid structures are not static. They have distinct maturation steps, and these distinct maturation steps are determined by their relationship within the tumor microenvironment. So the early immature tertiary lymphoid structures have very minimal architecture. They have weak chemokine and cytokine signaling, so the immune signaling and communication is not functional to optimize the immune recruitment and thus engagement and activation. And you have very limited germinal centers. So this is basically a forward camp that's completely dysfunctional. It's leaderless. It's not going to yield any results against the tumor. But a mature functional tertiary lymphoid structure is spatially segregated. Those immune niches are there, the B cells, T cells, dendritic cells, the high venules, but they aren't just there. They are in proper relationship, and they very closely resemble what was described as those ectopic lymphoid organ structures. They have active germinal centers, and these generate high antibody and high anti-tumor immune response against the antigens because the supply chain's there. They're properly related, forward training, and the different immune cells are properly spatially related to each other. And then there's regressive or dysfunctional tertiary lymphoid structures where they're there, maybe they're in proper relationship within the tumor, but they're disorganized. You know, the B cells aren't doing their part, the dendritic cells aren't doing their part, the supply chain's been disrupted. And so what we have here is not only with these regressive or dysfunctional tertiary lymphoid structures, not only a lack of anti-tumor immune activity, but actually can also lead to and support immune evasion. Tertiary lymphoid structures within the environment of the tumor microenvironment. So for example, they need to be just not anywhere. So it's not just those niches, it's not just the maturation, it's also the location. The intratumoral tertiary lymphoid structures are within the body, the tumor parenchyma, the rapidly dividing cancer cells. This is where you have the strongest association correlation with anti-tumor immune activity as direct access to the tumor, direct access to the immune cells to engage and train the immune system. Peritumoral tertiary lymphoid structures are at the invasive margins. They're a little bit outside of that parenchyma, and thus there's, some immune activation, but not really good immune activation. And here it can be a barrier to the immune system getting in that's keeping it out, the tertiary lymphoid structure that is. And then the stromal or distant tertiary lymphoid structures, here the tumor stroma is far from the tertiary lymphoid structure. So this is more of that immune excluded. It's on the outside looking in. There is less and really no coupled anti-tumor immune engagement with the tumor because the tertiary lymphoid structures aren't properly placed. So you can see the complexity of this spatial omics, this description of relationships. And yet we think knowing your lymphocyte number and giving something systemically is going to work when we see all this. So the spatial omic heterogeneity of the tertiary lymphoid structures tell us that cellular structure, location, and maturation, not simply the detection or number. Now, it's great marketing, but it's not science. Presence does not equal function. Structure does not equal productivity. Density does not equal immunity. Presence, structure, spatial, density is what equals immunity, particularly tumor immune competence. So I want to touch really quickly on peripheral lymphopenia and tumor infiltrating lymphocytes because there's another concept to this, not just spatial relationships, but the presence of immune cells in the periphery, in the systemic circulation. Does that then equate to what's going inside the tumor? Have to guess. Peripheral lymphopenia is being used as a potential surrogate for immunocompetence, and we can't do that. This is an imperfect relationship. The peripheral blood does not correlate in most cases with what's going on inside the tumor. I think the complexity that I just mentioned over the last many minutes shows that that's not to be true. So when we look at the correlation between what's going on in the blood and what's going on in the tumor, interestingly enough, is following chemotherapy and following radiation. So post-chemo radiation, post-systemic immunosuppression, which comes from chemotherapy and comes from radiation, and then radiation-induced lymphopenia. So the therapies that actually just destroy the immune system, they destroy it everywhere. They destroy it in the blood and they destroy it in the tumor. This is why it can kill cancer cells, but it kills the immune system, which buys time. But then once the immune system's down, the defenses are down, the tumor takes over when it's not completely eradicated. So that's actually where the correlation happens, when you destroy the immune system, because it's all destroyed. But yet, when you find naive tumors, patients that have not received chemotherapy, radiation, etc., untreated cancers, or immune excluded tumors, which is the dominant 50 to 75% of tumors, here is where there's actually some degree of correlation. Interestingly, before our standard of care treatment, chemotherapy, radiation, we actually can compare. Well, but I'll tell you that the patients that we see at the Williams Cancer Institute, 90%, oh, they've gone 6 months, 9 months, if not more, chemo, multiple rounds radiation. They receive systemic immunotherapy. Maybe there's been a partial response at some time. Maybe you have a remission of 3 months. And by the way, a remission of 3 months is not a remission. It's just we don't see it. I think there needs to be better definitions of what remission is, because I was in remission for 3 months. What happened after 3 months? Yeah, when it came back, it was everywhere. It wasn't remission. It was just regrouping. And the damage to the immune system by the treatment is what allowed it to regroup. I just find that fascinating, that the standard of care treatment is what creates the body-wide immunosuppressive environment that finds the correlation between the lymphocytes in the blood and lymphocytes in the tumor, because there's lymphocytes nowhere. And that's what leads to 90% of morbidity and mortality in cancer, because it spreads. See, the baseline here is that the immune response, it's decoupled. The tumor-driven exclusion mechanisms of the dysfunctional communication, the immunosuppression, the immune-excluded immune desert phenotypes, and the local spatial organization decouples the immune system, but it decouples the correlation between the blood and the tumor. In untreated disease, the tumor microenvironment, lymphopenia, does not equate. So in untreated disease, the tumor microenvironment, lymphopenia, does equate better to peripheral lymphopenia. Let me back up here. Conclusion: in untreated disease, the tumor microenvironment, lymphopenia, does not equate to peripheral lymphopenia. See, it only correlates when you destroy it. And so if you've had chemotherapy, radiation, immunotherapy, and you're looking at your lymphocytes in the blood, you have to understand that there's no correlation to what's that cell count is in the tumor, let alone relationship. It's the destruction by the standard of care that creates the relationship, because it's total destruction of the immune system wherever it happens to be. In the reality of the world, there's no correlation to what's going on in the blood from the cell and the count to what's going on inside the tumor. And there's a lot of these spatial relationships of cold versus not cold versus hot that are playing a role in that. I just find that fascinating, that it's the standard of care that creates that. So in the immune-excluded tumors, a critical decoupling happens because of systemic presence, peritumoral accumulation, and failure to infiltrate. So the cancer truth here: presence equals function. No, it does not. The cancer truth, that's the myth. The cancer truth is immune presence does not equal function. See, the different tumor immune microenvironments, they prove the presence of immune cells doesn't mean anything. It does not equate to anti-tumor immune activity at all, because they can be restrained, inhibited, suppressed, excluded, even spatially not organized or disorganized. And they can be far from the tumor parenchyma. The myth is the presence of immune cells means immune control. It does not. The truth is presence does not equal function, does not equal location, does not equal competence. Immune cells must be functional, properly localized, systemically competent, in proper relationship to each other. That's what equals anti-tumor immune competence, not simply giving something in the blood. And finally, cold tumors are untreatable. That's the myth. The truth is cold tumors can be converted to hot tumors and ignite the immune system. The immune desert, immune excluded zones, they need antigen release. They need danger signals and dendritic cell activation. And you can convert those cold tumors hot. But of course, this really is in support of why we believe that the intratumoral ablation, intratumoral immunotherapy is the way to reorganize the spatial relationship, the communication, the tertiary lymphoid structures, the different zones in relationship to each other, to move and pivot an immune desert and immune excluded, which dominate the variety of solid tumors that are out there, into not just an immune responsive, but an immune active, anti-tumor immune environment. So I hope this podcast has been helpful to you. Next, we're going to be talking about Know Your Number. That'll be the fourth in this line. If you're going to be at the Indianapolis, come by and see me. I'd love to meet you. I'd love to talk to you and hear your story and why you're there. We really need your help here. This is the third part of this myth versus truth as it relates to cancer podcast series. I encourage you to subscribe to this podcast as well as to the website and our newsletter, but also drop us a 5-star review. I'd love to hear what you think about it, how we can better serve you and empower you in your knowledge on cancer and cancer journey. And of course, follow us on all social media accounts. Like, share, subscribe there as well. And finally, check out the show notes where you'll find all the supporting evidence of this podcast. I'm Dr. Nathan Goodyear. I'll see you on the fourth part, Know Your Number, of the next Prescribed by Dr. Nathan Goodyear podcast.
Thanks for joining us on this episode of the Prescribed Podcast. All references supporting this episode can be found on the prescribed.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.